Good evening, ladies and gentlemen. If you've finished your tea and coffee, then we can start. Request you to please take your seats and please switch off your cell phones. We have a very interesting program today. We have 4 doctors answering questions about different kinds of common ailments. We have Dr. Sudeep Chatterjee, Dr. Abhrojit Ray, Dr. Shubhanand Roy, and Dr. Amit Ghosh, and it will be moderated by Dr. Debashish Dotto. I'll request Dr. Debashish Dotto to please invite all the doctors and take his seat here. Over to you, Debashish.
Thank you, Bartoda. At the outset, I would like to thank all the members for sending us so many questions, and I think we'll try and answer as much as possible. At Bengal Cup, we are very lucky to have very senior consultants who are all well-known in Kolkata and doesn't need any introduction. So here on my left, he's just walked in, Dr. Shubhanand Roy, our cardiologist. May I ask Dr. Sudeep Chatterjee, our diabetologist and endocrinologist, please come up. Can I request Dr. Abhrojit Roy, our rheumatologist, please, Abhrojit. And Dr. Amit Ghosh, our consultant neurologist, to come up. So there are many questions. So what we plan to do is over the next 35, 40 minutes, answer as many questions as possible. And then if you have time, we'll ask the members present here. You can ask short questions also. So I will start with Dr. Sudeep Chatterjee. As you all know, India is the diabetes capital of the world. Now, I met a friend of mine who went to a doctor for blurring of vision, to an ophthalmologist. And while examining her, the doctor asked, "How is your diabetes?" She said, "I don't have diabetes." And they said, "You have diabetes, and your eye problem is due to diabetes." So my question to Sudeep is, can diabetes present like this? Some say that it is a silent disease and can cause problems. Can it present like this? What are the complications you can see with diabetes?
Thank you, Didi. See, the statistics are that all over the world, approximately 5 to 10 years pass from the time you've actually had diabetes to the time you have found out you have diabetes. And this has been done with some elegant research. So this is a fact that, you might find out your diabetes when you're going to have your tooth taken out or a cataract done, or maybe some eye changes have already occurred. So this is something that does happen because the beginning of the diabetes is insidious. And unless you're happen to have a blood test, when you don't have any symptoms, you are very unlikely to pick up diabetes very. With passage of time, the problems with diabetes will slowly. So it's going to manifest. No, that's fine. So I think that's basically, it does happen, it can happen, and perhaps the way to go around it is by having blood tests at fairly regular intervals.
What are the complications you can see in diabetes?
Well, diabetes is a disease of blood vessels. And because blood vessels are everywhere, and the disease is also everywhere. Now, if you just simplistically divide blood vessels into big blood vessels and small blood vessels, the small blood vessel problems occur in the eye, in the nerves, and in the kidney. And the big blood vessel problems basically affect the circulation of the brain and the circulation of the heart. In fact, the most common cause of death in diabetes in approximately 70% of patients is either a heart attack or a stroke. And that is because it's a disease of the blood vessels mainly. Now, how high blood sugar causes a disease of the blood vessels is something that, is really not appropriate to discuss. You just have to take it as a given.
So I think one question which has come up, Sudipta, what should we aim for? What sort of diabetes control we should aim for? What sort of sugar level or HbA1c we should aim for?
Well, diabetes patient, you want to have a diabetes patient living a normal, healthy life. For that, we need to do 5 things. We have to control the blood sugar. The typical acceptable average would be 7%. We have to control the blood pressure. We have to control the bad cholesterol. We have to control or stop microprotein excretion in the urine. And before it becomes too obvious, at that point you have to stop it. And number 5, you should stay off tobacco in any form. Alcohol is fine.
You are very popular now, Sudipta. No, there's a question which has come up. The question is it acceptable to target the same blood glucose level for all Indians?
For everybody, not Indians, all over the world. Basically, we have seen that if we keep the average at about 7, the patients are best off. Now, there's been a controversy about 5-10 years ago that if you already have problems due to diabetes, then why bother to have such strict control? I mean, sort of a nasty analogy would be, supposing you've already got lung cancer, why stop smoking at that point? But that doesn't make sense in diabetes. You should always aim for HbA1c of 7% if it is feasible. If it is infeasible due to many reasons, then we have to settle for something, a higher percentage.
So the thing is, the HbA1c of below 7 is probably the target.
7-ish, yeah, maybe a little bit more than 7 or a little bit under 7.
I'll come to Amit. Amit, you see, in diabetes, a lot of people will have urinary tract infection, and that's often a presentation with an infection they come in. And you treat them, and they get better. But there will be a population who will have recurrent urinary tract infection. They keep on having the infections. So what should they do? How should they approach that?
Good question. Let's not make it into a classroom. Let's discuss it a little bit of social medicine. We classify this into males and females. Urinary tract infection in a male has to have a very, very strong underlying reason, which is not so strictly applicable to women. I'm not being sexist. This is actual hard data. The reason is a male, anatomically speaking, has got a long final passage called the urethra to void urine. The females haven't. That's how God built men and women. So God is sexist, not me. So therefore, if a male gets infection, we treat it more aggressively and try to find out that there is an underlying reason, which may be in the form of a stone, which may be in the form of an obstruction anywhere in the urinary tract, be it in the kidney, be it by the prostate, be it in the urethra, wherever there might be a congenital or an acquired obstruction. So if somebody is getting, as the question is, if somebody is getting a recurrent infection, we treat the infection the first go. But we also try and find out, is there an underlying reason, which may be a stone, an obstruction of some sort, and we need to remove that. Until we remove a person who has had a prostate enlargement and is blocking the flow of the urine, there will be jammed up urine which will promote infection. So there is no point in actually overusing antibiotics every time, wait for another infection. So that's about the male story. The female story, very, very prone to get infection because it's got a short urethra, so more exposed. The bladder and internal organs are more exposed. It's a myth, and there are many myths, I'll come to that. It's a myth that females get infection from public toilets. It's an absolute junk material, this data. If you at all get an infection, you will get a skin infection out of contact with a dirty toilet. But you cannot have infection climbing up the toilet into via urethra into the internal organs and cause an urinary tract infection.
But that's true for males also. For male patients also.
Males don't touch the toilet.
Okay.
Yeah.
But there's a concept that a lot of people will come with urinary infection, male patients, and say, I probably got it from the toilet. So
Yeah.
it's a similar.
I mean, these are myths and misconceptions. So therefore, in the female, there is a propensity for getting a recurrent infection for basically habits where females get inhibited to void and they jam up their own urine because they don't find a suitable toilet. And they promote the infection as a result. Adding insult to injury, if you have diabetes, the subject is already prone to infection. And therefore, in a diabetic subject, you have to have control of diabetes if you want to prevent recurrent infection. In case of females, it's more physiological infection if it is a recurrent infection. You will get it in both the age groups, in the sexually active age group and the sexually less active age group, which is the menopausal age group. In the sexually active age group, it is very important to know sexual practices because it is the sexual act where the sexual secretions are rubbed into via the private organs into the urethra, and that is how one gets infection. So it is extremely important to be aware how to take sexual hygiene more carefully.
The
And
question,
how to create more lifestyle changes, such as drinking more water, voiding more frequently. So my dictum in every social gathering that I go to, ladies, please void. Ladies, please void. Don't go under the dictum, it's a dirty toilet, and I will not void.
but Amita, the question here in elderly population mainly, do you think that people should take prophylactic antibiotic to prevent infection?
If there is tremendous recurrence and recurrence into the order of 3 consecutive infections,
Okay.
because remember, the most common cause of recurrent infection is self-treatment without knowing whether you've got the infection at all or not. Because there are problems where you mimic infection. You're going to the toilet more frequently, or you're getting a little bit of burning in the micturition, and you are actually assuming that you've got infection.
So it's a proven infection you're talking about.
Yeah, it has to be a proven infection.
So moving on, diabetes and heart, Shumananda. It's a big issue. So a lot of diabetics, as I understand, may not have any heart symptoms. Do you consider that everyone should be screened, diabetic patients, for heart disease?
Yeah, basically diabetes is considered as heart disease equivalent or other way around. So once there is diabetes, we take the patients very seriously, whether they are having ischemic heart disease or not. And every diabetic person should be screened, particularly if they have other risk factors for coronary artery disease, as for example, the dyslipidemia or cholesterol, bad cholesterol is high, or the patient might have, hypertension. So these patients, they are smokers, basically if there is a risk factor in diabetes, particularly male sex, and those who have family history of ischemic heart disease, they should be screened for ischemic heart disease. There is no doubt in it.
Nowadays, what we are noticing, Shubhanda, is there's a lot of young population, young patients in their 40s, even 30s, getting heart problems, heart issues. Is there a genetic predisposition? Why are they getting... When we were studying, we didn't see so many young people getting heart issues. Has things changed?
Yeah, this is basically a very important paradigm which is happening I would not say that it is happening throughout the world. It is less common in developed countries. It is more common in developing countries. Like if you look at the childhood of our people, our children, you will see that these children are not having a lot of exercises. They go to a lot of academic institutions, have a lot of things, but do not exercise a lot. And childhood obesity is growing very, very fast in our country. And as we know that the atherosclerotic disease or coronary artery disease starts at the age of 2, maybe. And gradually they become more complicated and manifest as coronary artery disease in the 40s or 60s. Now what happens when there is a obesity in the children, when there are risk factors, these risk factors, they play around with each other and they form complicated plaques even in the age of 20s and 30s. That is the main reason of having early or precocious coronary artery disease in our country. So lack of exercise and childhood obesity, these are the very important pointers for having ischemic heart disease at a very early age.
So we'll discuss about obesity in a bit, Sudipda. Because I think what you are saying is not genetic predisposition, it's mainly obesity which actually triggers
there are
it.
some, there is not really a genetic factor which is working for development of coronary artery disease, but there are some associations. Like, risk factors, they are associated with bad prognosis in our, Southeast Asian countries. It may be a genetic background which we do not know, but probably it is a very well-known association which we can see altogether.
So, Abhijita, when we are talking about young people, there is another question that someone wakes up in the morning, a young lady, with swelling of hand and feet, and can't get out of the bed. What should they do?
Now, let me warn you, rheumatoid arthritis and ankylosing spondylitis, all are inflammatory arthritis, is increasing in incidence throughout the whole country. We are finding statistics suggestive, and if a young lady, the ideal age is between 15 to 45, if she can't wake up from her bed in the morning because of painful and swollen joints of the hands or feet or both, then you have to suspect what is called inflammatory arthritis. Fortunately, most of the inflammatory arthritis within the first 6 weeks are because of viral fever. Could be dengue, chikungunya, some flu-like symptoms, which will pass away. But if the symptoms persist after 6 weeks, especially with a strong family history, the mother, aunt, or anybody having some degree of rheumatoid, then you should be properly investigated, and early inflammatory arthritis should be arrested. What is important to realize, you can't cure rheumatoid arthritis technically, but you can arrest the progression of the disease and its propensity to cause damage. It does damage the joints, everybody realizes that. You wake up in the morning, you can't make a fist, you can't hold a pen, or in front of the computer you are unable, or because of the feet problem you can't walk properly. And that also has a lot of problems because ultimately it also affects the heart, lungs, it can affect the nerves slightly. Much more common is dry eyes, which is very common. The young kids always looking at the blue screen, whether it's a mobile, the computer, anything. So rheumatoid has to be treated early, especially if the symptoms and signs persist beyond 6 weeks. Otherwise, early stage, before that, it can be self-limiting, in other words, it can go away.
So they need to go and see you early and not wait. That's the message
6
coming.
weeks minimum.
6 weeks.
6
I think
weeks
6 weeks is a long
dividing
time.
line. And
Now-
as Sudipda suggested, smoking is a strict no-no, both for the cardiologist, the diabetologist, and also for us, because smoking aggravates it. Gum health is very, very important. Please ask your kids to maintain their dental hygiene.
Thank you. But in the same context, an elderly lady, actually I'm also getting it, gets a lot of painful knee and struggling to walk. What should they do?
Now, this is what you technically call arthritis, buzurgo ka arthritis. That's the standard osteoarthritis in general. And the reason is usually the people are overweight, diabetic, hypertensive comorbidities, and they can have a strong family history of the relatives having weak knees or affected knees. And here the difference is subtle. You wake up or you stand, and the knees hurt you for a few minutes. It's not half an hour or 1 hour. If you want to stand, you are imbalanced for a few minutes, then you get over it, then it's osteo. You can also get the grating sensation, the crepitors, the noise as the disease advances. And as you progress, most of the primary osteo, not the inflammatory, secondary inflammation, they usually have a bent knee, which we call technically genu varum. You can see when the lady is walking to the door, it is unfortunately more common in ladies, but it does happen in men. So when you're walking through the door, you're having a look at the gate, the house she's walking in, and then you know that, come on, what I'm handling. For a young girl, yes, the hands are crippled like this, she's in pain, you can make out. For an elderly lady, if it's very advanced, the walk is very abnormal, the first question I asked, have you come back from an orthopedic surgeon who has suggested a bilateral TKR? That is my first question.
But there is a concern, Obroda, the medications which you give for rheumatism. Now, does medication for rheumatism affect other organs in the body? Maybe GI, like what we are dealing with?
Yes, I believe all of us are aware that besides the healthy lifestyle and everything which is advocated, the first line of treatment is the so-called painkillers, which we call NSAIDs, non-steroidal anti-inflammatory drugs. And all of you are aware, they cause gastritis, peptic ulcers, and that will land up with Devashish, with the gastro problem. They can have GI bleeds when obviously it is. Besides, the kidney toxicity is important. Renal toxicity, we have, as you know, what is called type 2 selective, like etoricoxib, celecoxib. They cause less gastritis, they're more stomach friendly. But so far as the kidney is concerned, they are equally bad. And some of them also have cardiac toxicity. So that is the important point. So it might walk into his clinic with a heart failure or some other problem.
So I think what you are saying, Abhijita, is that early diagnosis, early treatment can arrest rheumatism. But for osteoarthritis, some of them will need knee replacement and stuff. Amita, back to you. I've got an interesting question here. This is often not discussed, but there will be a group of elderly lady who will have urinary incontinence. So when they cough, when they sneeze, sometimes the urine comes out without even knowing. How do they handle this? And what should they do? Maybe see you, but what's the way to manage these patients?
If you look into the history of this and you interrogate them well and get over their embarrassment, you will find that this is not a recent problem. It is a very old problem, mostly starting from childbirth. You will be surprised and how much worldwide, it is not an Indian culture, worldwide women are experts at suppressing this fact that they're actually getting wet, particularly when they get up from the floor or from the chair or when they cough and sneeze, which is called stress incontinence. That's one category. And this happens because during childbirth, as a result of the hormonal changes and as a result of natural labor, there is some stress and damage to the muscles of the pelvis which are responsible for continence. So therefore, it is very important to make ladies aware that as soon as you get that, please consult the doctor. As soon as you get that, please consult the doctor. Do not wait until your old age and non-childbearing age, because this thing, which was minor, will become a major factor when you grow old, because you're going to naturally get weak. All your muscles are going to be weak. You're going to get comorbidities like diabetes, etc., which will make it worse because there will be myopathies, which will actually increase your incontinence. The reason is there are easy remedies to start with. You start with simple exercises of the perineum, which will enhance the ability of the muscles to hold back your urine, and therefore it is important to start there. There are nowadays medications to do that. However, medications are for a different category with cortisol. I'll reflect on it in a moment. There are, in your young age group, when you're hormonally active, if you get yourself repaired, if suppose for a period of time you're not getting continent with your exercise and your natural healing, there are operations where you can actually support the bladder and the angle of the bladder and the urethra, whereby you will get back your total continence. Simple operation, not extremely difficult, and therefore please act sooner rather than later. So that's my first advice. When you're in the old age group, unfortunately, you will have to fall back on your incontinence pads. Little you can do, you can still do the operation, but risks are there, and you will not have that tenacity and the muscle strength to recover the muscle which is already dead and gone. So you will not get support from your own natural muscles. The other category is the urge incontinence. This is a common phenomenon in the sexually active age group, whereby you get incontinent because you're getting recurrent infections, and this is the problem of the bladder. The bladder, I'll give you a simple example. You drink 2 or 3 cups of tea and coffee. All of you, without exception, will get an urge to go to the washroom. In this room, I'm talking about. Everybody, young and old. So this is a phenomenon by which the caffeine in your tea and coffee stimulates the nerve endings of the bladder and gives the local signal to the bladder to void. Now, if this becomes excessive, we call that condition an overactive bladder. And recurrent infection tends to give you that gift of life called overactive bladder. And therefore, what happens is, as soon as the bladder produces a little bit of urine, the kidney produces a little bit of urine and collects in the bladder, you get a signal to go and void because the bladder is overactive. But the good thing is, this overactive state can be controlled by lifestyle changes, number one. You drink less of fluids, you drink less of caffeine-containing beverages, and there are very good medications where it will change your lifestyle upside down. People who were completely incontinent or used to run to the toilet every half an hour will actually go 3 to 4 hours, every 3 to 4 hours without being wet at all. So, ladies and gentlemen, overactive bladder is something you all must be aware of. Your fluid habits is your lifestyle change. You don't have to go to a gym to encourage your bladder. All you have to do is regulate your intake of the quality and the quantity of the fluids that you take, and please take help of medication. Please remain young while you're trying to correct this, and don't wait for your old age and your pension plans to take care of yourselves. Thank you.
Well said, Amita. I think the important thing is, if anyone has symptoms like this, they should actually try and get treatment, because there's very good treatment available now. I'm coming to the meat of our discussion today, obesity, Sudipta. I think that's a huge problem these days, and as Shubhananda was saying, or Abhijita was saying, it's a root of many problems. So what should we do? Diet, exercise? I understand there are many fancy new medication which actually helps in obesity.
We could talk about this whole evening and not get anywhere about obesity. The problem is that not a single overweight person wants to be overweight. There's no doubt about it. They're not overweight because they want to be overweight. Thin people are different. Some want to be thin, some want to gain weight. Now, in spite of this very burning desire, why do we have these pictures of the richest man in India's son, who was, well, over 100 kilos, then slimmed down to 70 kilos, and is back to 100 kilos. So the clear message is that money can't buy you slimness. So what can? Well, the problem is that our eating habits, our eating patterns are set in a tiny little area behind your nose, somewhere there, inside the tiny little area, as the feeding and satiety center. And the settings are more or less set in young adulthood. And the rest of your life, the body will try to defend that weight as much as possible, punctuated by pregnancy and punctuated by stress issues. Stress can increase your weight, and very, very rarely disease. Now, the saddest point is that we can't approach this set point and reset it. It's not like setting your watch when you're traveling abroad. This is, as of now, unsettable. So all the treatments we have are downstream. They can be treatments that make you less hungry. It is not a very pleasant thing to be, state to be in. There are treatments that can make you digest food inadequately or less well. So even if you eat, it just passes out undigested. And of course, you have diet after diet after diet. So I just would say that, if there was one diet that worked, you wouldn't be having diets coming and going every 6 months. Because the one diet worked and everybody would follow that diet. So we've had these keto diets. They've gone because they have been shown to cause more heart failure and heart attacks than actually make you feel good. Current rage is, of course, intermittent fasting, which is actually a younger brother of that ketogenic diet, and again it is showing problems. So, it's an issue that requires a lot of willpower to try and override your urges of eating and your satiety. And exercise, if you can exercise, say like a footballer. I've never seen a very obese footballer, have you? You've never seen a very muscular footballer either. But you've seen obese or muscular old-style cricketers, javelin throwers, weightlifters, boxers, and so on. But no cricketer, no swimmer, runner, etc. are obese or very muscular. Reason is they don't feel very hungry. It's that type of exercise takes away your hunger. So if you exercise and feel very hungry after exercise, that part of exercise, I'm sorry to say, is a flop, so far as weight is concerned.
Any particular exercise, Sudipta?
Well, cardio does make you less hungry. First of all, exercise, it must be safe for you. Second, it mustn't cause injury. After that, it's best to exercise up to your limit. And if you're really, succeeded according to your own limits, then you really don't feel hungry after exercise. And that's a very good pointer. And exercise doesn't mean anything is better than nothing. But we are talking about weight loss here. So, we're trying to put it in a little more, what should I say, forceful fashion.
I've got a very interesting question from one of the members. In spite of medicines prescribed by doctors for abating diabetes, patients are advised to maintain a restricted diet. All charms of eating are lost. What is the point of taking medicine then?
Very good question. I'm so glad somebody asked this. And it should get a prize. Because this is actually a question that people have in their hearts when they come to see me, but it doesn't come out through their tongue. So it's very, very good. Thank you, the questioner. Now, actually, I will just share one example, of one aspect of my practice, which I've been doing in Kolkata for about 30 years. I never had a diet chart. I never gave patients diet charts till post-COVID. Post-COVID, the demand was so, what should I say, insistent, that I started printing my first diet charts after approximately 25, 30 years of practice. Now, what does that mean? That basically means You eat what you like. What we would like is that you do not gain weight and you do not eat foods that will spike your blood sugar. Example, if you have, Bengalis do put sugar in, a lot of cooking. So if you put, say, 1 teaspoon of sugar in some vegetable preparation, it's not going to bump up your sugar. But if you have 1 spoon of sugar in your cup of tea and nothing else, then that sugar is going to spike. So we don't want you to have foods that will cause the sugar to spike. So I don't have sugar, sweets, cold drinks, ice cream, and so on, unless you have it very occasionally with a mixed meal. So that leaves you that you have pretty much what you want to have, provided your weight doesn't go up, which means your total calorie intake is good. And second, good, appropriate for your lifestyle. Second, you don't eat foods that will spike your blood sugar, except small quantities in the setting of a mixed meal. So, I hope I have been able to answer the question of the.
I think you've heard the diabetologist. I'm going to ask Abhijit, can rheumatism be controlled by diet?
This is not working. There was a study. 94,000 American ladies were taken between, 1991 till 2011. And they were 94,340 developed rheumatoid arthritis. And they found that if you went for a truly American diet, which is processed meats, red meat, deep fried stuff, potato crisps, ice creams, everything, including the fizzy drinks, you had a much higher chance of developing rheumatoid arthritis as compared to if you went for salads, vegetables, olive oil.
Mediterranean diet.
Exactly, Mediterranean diet, fish, which is good for you. So, but that is not 100% proof. But yes, definitely diet helps. And my recommendation to all my so-called inflammatory arthritis patients, take dry fruits, 4 almonds or could be walnuts or something a day, which actually gives you a bit of taste as well. Even sesame seeds and others. And the most important thing in rheumatism is the fish olive oil, the omega-3, which you can get easily. And they definitely help in the rheumatism.
So omega-3, Shubhananda, does that help in, so 2 questions, diet specifically for cardiologists, advice from cardiologists, and exercise, role of exercise in preventing heart disease.
So I should begin with the exercise. We know of a physician who is a very celebrated physician in America. His name is Paul Dudley White. And Paul Dudley White was famous because he saw the American president, the then president, Eisenhower, when he had a heart attack. And that time, in 1955, heart attack was a taboo. And after heart attack, people thought that, yes, that life is over. So what Paul Dudley White did, he advised the president to play golf. And with the swing of the golf club in the old television, the cardiac rehabilitation started. So exercise is the most important medicine for lifestyle modification. And in every case of heart disease, exercise reduced mortality. There is no doubt in it. But what should be the exercise? What would be the type of exercise? We call them FIT: frequency, intensity, time, and type. So FIT means F-I-T-T. These 4 the things should be remembered very often. So what is frequency? The best exercise perhaps at our age group or adult age group, not in children, would be the moderate walking. What do you mean by moderate walking? Nowadays, when I walk, people ask me that, doc, what is the pace I should be walking, and what would be the intensity of the walking? Should I brisk walk? Then we need to answer this. What is brisk walking? When you walk without panting, just before panting. If you walk in a more speed, that you will be panting. But before that, if you walk with your friend talking normally, that is a brisk walking at your age or at your status. So, having brisk walking every day, at least 5 days a week, at least 30 minutes a day or even more, is the best form of exercise at our age group, or somebody who is having a heart attack, or somebody who is recovering from an angioplasty. We tell them that yes, you walk briskly, and we explain what is briskness, and do it for at least 5 days a week and more than 30 minutes. And if you can go up to 1 hour a day, that is enough.
So 5 days a week, 30 minutes.
Very, very important. And intensity should be brisk walking, that is moderate. Like you can play golf, you can play badminton or tennis, not competitive tennis or competitive badminton, leisurely. And you can swim, not competitive swimming, but swimming, normally swimming. So these are the exercises which should be a must for every person who is having heart disease or who is not having heart disease for prevention.
So I'll stop you there, Shubhanda, because we are running out of time, and I've got many questions, so I'll just go through them quite quickly now. So, a very common thing, Shubhananda, coming from a gastroenterologist, there are patients who will come and say, I'm getting a lot of acidity, bloating, flatulence, which is very common in Bengal, what we call gas. Now, do we always think that it is actually acidity? Or do we think there might be something else going on? Especially at night, someone suddenly wakes up and gets a bit of a acidic feeling, not settling down. What should they do?
They should they should call a doctor and go to a hospital, because in our practice, what we have seen so many years is that any acidity or a bloating which can get yourself awoke in the night from the sleep, it must be cardiac. It's nothing, it is no gas.
Is there anything called golden hour, that if someone gets a chest discomfort, that they will need to see the doctor as fast as possible?
Here I would point out one thing. It is chest discomfort, what he said. It is not chest pain. People come to me and I said, Doc, I do not have chest pain. I said, no, it is chest discomfort. Any discomfort which is in the chest, which you have not experienced before, and it is not going out, and it has caused awakening at night, you should go to a hospital. Get an ECG done, because the golden hour is 2 hours. If you do something within 2 hours, the chance of survival is much more, 90%. So do not miss the golden hour.
I think I brought this question up because as a gastroenterologist, I see a lot of patients coming to my clinic saying, I'm having a bit of a chest discomfort. I think it's gas, I think it's acidity. If there's ever any doubt, I think it's very important to rule out any cardiac problem. I think this is very important, especially it happens quite often at night and people tend to ignore it. And I think it's very important. Shubhananda, you are a master in putting coronary stents, so angioplasty. See, you are very good at it, but the two very important questions is, what happens when there is a blood clot inside a stent? Or do we need to replace stent every 10 years? So what do we do as a follow-up?
Basically, if there is an artery which is clogged, narrowed, we used to open it with a balloon. Then initially it started with, in 1979 and gradually progressed. But we saw that there is a re-narrowing of the artery after 3 to 6 months. So came the stents. That could prevent the re-narrowing in around 70% of the cases. Still, there was 20% chance of getting a narrowed out stent. Then came the drug-coated stent. And every time we are giving a price, like, in drug-coated stent, only 5 to 7% of the people who are getting drug-coated stents are having restenosis or re-narrowing, but it acquired, dangerous disease. In 0.6% of the people whom we put drug-coated stents, they got a clot inside the, drug-coated stent. Maybe within the first 15 days or 1 month, we call it stent thrombosis. The stent thrombosis is a dangerous thing and it can kill a person. So the people who are getting who are having angioplasty, we tell them that you must have to continue with your dual antiplatelet drugs or blood thinners regularly. Otherwise, there will be a chance that you will get a clot inside your stent and the stent will be clogged. So if somebody gets a drug-coated stent, remember they do not stop the antiplatelet drugs or the blood thinners without advice of a physician. First of all is this. And number two, if there is a stent put in your coronary artery, there is in 95% of the cases the stent will remain forever. There will be no problem. Only in 5% of the cases they can have narrowing of the stents. In that case, we dilate the stent by a balloon and put some drug in it. That's it. Stent should not be changed and cannot be changed.
Thank you. I think we move to a very important topic, Amita. Question about prostate. So, with increasing age, most people will get prostatic symptoms. So, when should they see a doctor?
I'm going to ask you, I'm going to ask the audience a question. For all the male people, are you all born with a prostate? Yeah? All the male people, are you all born with a prostate? I ask this question because in my long 30 years of practice in Calcutta and abroad, when people come in with prostate problems, they first enter, they say, "Amar prostate hoyeche." So that's the first myth. We are all males are born with a prostate. What happens is, like the menopause, men also have andropause, which is there is a hormonal change around the age of 50. And the prostate, because of the changed hormonal milieu, the prostate starts enlarging. And prostate is a gland. Like the tonsils, we have two glands on two sides of the neck. This is a single gland, pretty much useless. A small gland, only God has given us this gland to cause problems. Okay? It has got no utility that humans so far know about, except when you don't know anything about anything, you say stop smoking. Similarly, you don't know anything about the prostate, people say that it gives some nourishment to the semen.
But when should they come and see you? What are their
They
symptoms?
will come when this enlargement is trying to cause a problem in the patient. For instance, a normal weight of the prostate is a 10-gram prostate. And it is a culture now to get a health checkup, which is driven by commercial reasons more than necessity. And then what happens is the ultrasonography tells you it's an enlarged prostate. It doesn't matter. And the common rebuttal that I give to the patient is, I have got big eyes. And the Chinese population has got small eyes. So what's the difference? The difference is I don't see more and the Chinese doesn't see less. It's a question of what the eyes can see. Similarly, in a particular individual's case, what the prostate can do to the flow of the urine is what matters. And therefore, that will be reflected in a slow flow of the urine and getting up too many times at night or going to the washroom very frequently in the daytime, even though you restrict fluids. So, all this symptoms, complex of reduced flow along with frequency, either in the day or night, is what should attract people. That's the first category. The second category, of course, with the gift of corporate hospitals, health checkups are very, very important nowadays. I will not try to justify it or antagonize it, but if you get a PSA, I don't need to probably explain it, everybody knows what a PSA is now. If a blood PSA level is high, which may indicate a cancer, that is when you visit a urologist.
On this note, there's an interesting question which has come up. Is it advisable to remove the prostate gland after 75 if it's of no use?
Males are not like Angelina Jolie, so therefore I think this question doesn't stand ground. And I would say, please never even visit a doctor if you don't have symptoms or if you don't suspect a cancer. If there is no doubt of a cancer in the family, please do not visit. Not only a doctor, please do not visit a urologist.
So that's coming from a urologist, not a gastroenterologist.
Please do not. There is too much excess workload in the way of aged population doing nothing at home except visiting the doctor.
Abhida, there's another interesting one. Now, going by the bypass, if you are driving through it, you will see a lot of advertisements about robotic surgery. So what's your view on robotic versus
The first
conventional
myth I
surgery?
want to break about robotic surgery and microsurgery. Now, this is a microsurgery is a geographically defined definition by the Bengali community. There is nowhere in the dictionary anywhere called microsurgery. Okay? So this microsurgery Bengalis have designed, not even the non-Bengali population of Calcutta. This is a loved phraseology entirely designed by Bengalis. Micro meaning small, and therefore that is what they've designated this entire operation to. This operation, this big operation of the prostate which we do and is our bread and butter of removing the prostate gland by so-called inverted commas microsurgery is actually removal of the prostate endoscopically. So Bengalis have, alu chater moton naam diye diyeche microsurgery. So therefore, this is microsurgery in the sense that, non-invasive surgery. That's what they meant, really. Now, the new kid on the block is the robotic surgery. Robotic surgery is meant for removing entire organs, mainly suffering from cancer. Now, this is extended to other avenues as well. So, in my specialty, and particularly in the prostate organ, if you have got cancer prostate, then only robotic surgery, where we need to get into the abdomen, but outside the prostate, and you entirely remove that, anastomose the bladder with the rest of the urethra, that's robotic surgery. Nothing to do with the normal routine practices of surgery on the prostate, lovingly called microsurgery.
Thank you, that's very nicely explained. One quick question, Obhajit. Please give us a short answer. Leg cramps at night. A lot of people suffer from leg cramps. What's your solution?
Leg cramps are often due because of thyroid problems, hypothyroidism, etc. They can be because of sodium-potassium electrolyte imbalances. They can be also because of poor blood vessel supply to that area. That is possible. Peripheral vascular disease can also cause leg cramps. And so I believe sleep at night, especially if it's shallow, sometimes it can be disturbed because of leg cramps. So if you look at the common causes and solve the causes.
Is quinine any good?
Quinine was used a lot in the UK. We used to give a small tablet of quinine for preventing leg cramps. Here, because quinine can cause a vision problem here, I tend to avoid it. I give something else, either Rivotril, which is clonazepam, which can work, or earlier stage, vitamin E and cod liver oil, Evion, can be harmless. It can definitely help your leg cramps, unless you have thyroid and other problems, electrolyte problems, which can be sorted the normal way.
Thank you. I think we have almost been discussing for an hour. So my last 4 questions, all from members, and they're all very interesting. And I'll ask the panelists, whoever wants to answer this. The first one is, how does non-human relationships help or problematize today's lifestyle and its link with medicine? Anyone? Well, I do not know the answer to this. I think it does change things. It can help in certain ways. I think if you have got, for example, pets at home, sometimes that helps to calm you down. Sometimes when people are very stressed, even watching football can help them. But on the other side of the coin, that if you have ignoring your symptoms, ignoring your disease, by doing that, that may be harmful.
Can I just add one more thing? I think you're very right. I think non-human modes help as a stress buster. And please remember, if one message you take out of today evening is that stress is an abstract issue, very subjective, not to be ignored. In this day and age, the biggest disease cause today is stress. Whichever way, you can talk about diabetes, you can talk about heart disease, you can talk about urology. If you are stressed, you will go to the toilet. If you are very stressed, you will have a heart attack. If you are very stressed, you will have a very high sugar. So stress is a common platform. And these non-human commodities actually help in stress busting.
I hope it answers your question. The next interesting one is, as specialists, is your treatment of patient-specific or holistic? Do you suit medicine to patient or patient to medicine?
Can I answer that? It has to be holistic. It cannot be individual. You cannot treat, and this is my biggest regret, and I'll express that in front of you, the change in specialization, the change in medicine, healthcare today is that we have become super specialized. We have lost the culture of general physicians who used to look after people holistically. We are very disease focused. Within the disease, I mean today, I'm ashamed to say, in urology, there are prostate specialists and stone specialists. People who can do prostates can't do stones. People who can't do stones can't look after their sex life. People who look after sex life have got no idea about treating prostates. So this is the malady today in the healthcare. If we run away from our responsibility of delivering holistic healthcare, I think doomsday is about to come.
Anyone else on this one?
I believe in our lines as holistic medicine, there's no comparison. You have to see the person as a whole. Especially my patients of rheumatoid, the young ladies, angst, the young men, all have depression and stress written all over them. So if you are treating just the disease without teaching, without de-stressing them, at least see the mind aspect of it, the mental aspect of it, your treatment is bound to fail. Sleep disorders, everything has to be addressed to appease the patient, to calm them down, so that the disease level also comes in with the control of stress.
Shivananda.
Basically, I think that in the present day healthcare, it's not possible to be holistic by a single person. It is absolutely impossible. Like, if there is a job which is very specialized, like, I put stents, it is very difficult for me to see all over the patient, like what would be his diet, what would be his gastric condition, what would be his diabetic condition. I need help from my fellow physicians. So basically it is a congregated effort from every one of us. And basically what we miss nowadays is a general physician or internal medicine specialist. The problem of our country is initially it was a base of a pyramid which was made by internal medicine or general practitioners. Now, gradually, they refer the cases to the specialist, and gradually we ascended over the pyramid. But the pyramid is now upside down. There are more specialists than general physicians and internal medicine specialists. That is the problem, there's a crux of problem which is happening now. We need more general physicians and internal medicine specialists. We can do justice to their patients.
There's a comment.
My name is Hirak Sen. I'm a member of this club. I lived in England in the previous century for about 10 years, and I had a GP. Anything happened, I went to my GP, and he routed me to wherever it was. Fortunately, I didn't have many routing, but I saw him regularly. I lived in the United States this century for a few years, couple of years. I had my PCP, the primary care physician, I was very careful in choosing my PCP. I chose a venerable professor of Tufts University, and he oversaw everything. Where is that culture? Can we not introduce that culture in India of a PCP or
Can I answer that? You see, NHS or the US system works very differently from ours. Our system is private run, and it is often financially driven. So the earning of a specialist is very different to earning of a GP. So if you ask any new doctor who is graduating and who wants to do private practice, they would much prefer do a specialist job and do cardiac stenting rather than see 50 patients in a day. So I entirely agree with you. That's the ideal situation. But unfortunately, that's where we live in. I think unless the government sector changes completely, I doubt we will have, unfortunately, more general physicians as we crave for.
Can you not put pressure on the government from your medical association?
Yes, I think so. This is my little 2 paisa on this. I think we should have a different session on this, on healthcare. This is not disease, this is healthcare management. And we as a club and as an elite society of this country, we can actually propose this. If you look back into the anatomy of a structure of Calcutta, the British had actually put in clinics, corporation clinics in every locality of Calcutta, which has gone into disrepute, and it is in a shambolic state of affairs. We just need to revive that culture, and we will have this holistic medicine back again.
That's for another discussion. Last 2 questions. Did you choose this career? This is for the panelists. Did you choose this career as your passion, or because of a tradition, or was it an obligation or a necessity? Well, if no one answers, I will answer this one. I didn't know about medicine. My family is a family of lawyers. My father was a barrister. My grandfather was a lawyer. And I was told that I'm doing medicine. So I even didn't sit for an engineering exam. And luckily, I passed the exam and I became a doctor. And the lucky thing is that I still like the profession. If I didn't like it, God help me. So I don't think the other panelists want to answer this one. My last question to all of you, 10 seconds, please. What should be the most important lifestyle change in our times to minimize falling ill? Amita.
I can't answer you in 10 seconds because it's a very interesting question to wrap up. Lifestyle change from the automobile revolution in 1920s. And if I am privileged to actually service that population, and which is actually dying now, old age population, they are so fit, bereft of diabetes, bereft of cardiac diseases, because they have had the habit of walking every day. And that is the biggest lifestyle change we really reintroduce now and emphasize in such elite gatherings. But at that time, there was no choice. There was no lifts, there was no automobile, there was nothing. And people used to walk miles to go to the office. And that was natural. So it reminds you, if you study history, it reminds you actually that lifestyle change fundamentally is you be natural and not artificial.
Well said, Amita.
Well, you see, people have studied these long-lived populations, say in Okinawa or in Sardinia. They all have several things in common. They are rural or semi-rural. They have to walk a lot, usually up and down hills and down vales. They have a lot of animals with them, and they enjoy wine. Now, it's a pretty boring life, at least what BBC shows us, but they live long, and they are all very thin and very active. Now, which parts of these lifestyles you can incorporate in your day-to-day life is the question, the challenge, what you have to answer for yourself. This is not a medical prescription, this is basically common sense. And the items are there on the happy living, healthy living sort of buffet table. So you have to take your plate and pick up what you can put in your life.
Besides diet and exercise, I believe no smoking. I have patients who have said, Dada, onek komiye diyechi, chhere diyechi. But I must have my last pull, at least at least 2 sticks a day or at least 1 stick a day. And I have to put my foot down and say, please no. Because you land up with a cardiologist, you land up with arthritis, you land up with diabetes and other flare-ups. So please no tobacco. Wine is acceptable in moderate proportions, but no tobacco.
And the last portion, maybe, I would say that lifestyle modifications should begin early. We have to give our children, give back the childhood, you know. We have robbed the childhood from them. Basically, if the children do not find a place to play, and even if you see the old institutions like his institution, it's 2 big grounds. So even nowadays, most of the schools do not have a playground. So if the children do not exercise or do not play, glued to the television or tab, there will be childhood obesity and there will be disaster, and we will get earlier angioplasties, 20, 30s, heart attack and angioplasty. It is a dangerous thing. It will destroy the society. So charity should begin at home, and the lifestyle marketing should be started very early in life.
I'll just say one thing. Shivana has made a very good point about lifestyle starting early. What I would differ is that there should be no lifestyle modification. It should be that lifestyle from day one or minute one, and no question of modification.
I've got only one comment here. When my patients come to me, I ask them to do one thing, to buy a weighing machine. Because a lot of them have got fatty liver, you see, and GI symptoms. I say to them, if your weight is good, and if you've actually lost 5 to 10% of your weight, you'll be okay. So my lifestyle advice is monitor your weight. So what I've done is, we have almost come to the end of this. I think we have been discussing about more than an hour. So I'll ask the audience, our members, if anyone wants to ask any questions.
One question is, when we're talking about the holistic look, loneliness and the feeling of abandonment or lack of socialization. When we're talking about kids not playing in the school, not having friends, because there's a very important book, I think it was Blink, where they talked about the role of the community. So I'd like some.
I think that's more of an interesting comment. I don't think.
When you said that we should test our blood regularly to check whether we have diabetes or not, do we require the fasting and the PP test or just the HB1?
The HbA1 in South Asian population, one should not use the HbA1c to diagnose diabetes. I think anytime you're giving your blood tested, you can do what is called opportunistic testing. That means just get the blood sugar test whenever your blood is being drawn. And if it is anywhere, say, these are not documented, but anything more than, say, 150 or something at any random time, maybe you should get a formal fasting or a PP glucose.
Hello, good evening. My question is to Dr. Chatterjee. Sir, I've got actually 2 questions. Number 1 question is, does diabetes cause itchiness of skin? And secondly, when you mentioned about obesity, and you said that, all of you said that we need lots of exercise. In today's age, most of our children, where do they have the time to exercise? If, like my son, he is in a government college, and the amount of workload that is there, he is working from 6 in the morning till 10 at night. So, and he doesn't have time to eat as well. But in spite of that, he's gaining weight. So much so that he's not even obese. If there's anything called over-obese, he's that. So how to avoid that? Thank you.
Yes, diabetes does cause dry skin. And dry skin is usually an itchy skin. And it's no point really going to a dermatologist because it is not, the skin is a mirror of the body and it's not a skin disease per se. Regarding exercise, you are not going to lose weight by exercising. For example, you're going to burn up one piece of buttered bread by very rapid walking of 5 kilometers. So it is better that it doesn't get into your body in the first place. Exercise has got many other benefits, and it does, if it is taken to your maximum limits, which I wouldn't say is good for everybody, it actually reduces appetite. Now, if you are extremely obese, first that motivation has to be there rather than that abstract wish that I wish to be slim, which is in the breast and mind of every single obese person. Now, we have to think of practical strategies which have to be customized to that particular person or to that particular lifestyle of that person, who has to realize that some amount of discomfort is necessary. I tell some of my patients, skip carbs for dinner. Immediately they will say, what will I have then? But that's not the point. You are going to skip carbs to give yourself some discomfort so that you lose weight. It's not fun. It's by no means fun, but because, first of all, you want to fit in. Secondly, because of the health benefits, myriad health benefits of losing weight, you want to do it. So it is an uncomfortable thing to lose weight, no matter what you do. And how much you're going to be motivated requires a very personalized approach.
Good evening. I'm Sujata Roy, a member of this club. I don't have a question. It's just an observation or maybe a request to all of you who are medical practitioners, all established doctors. See, quite often what we've seen is when we visit a doctor and we ask questions, it's not really encouraged. You ask two, 3, 4 questions, and finally we land up with an answer, "Apni ki doctor, apni shab bujhen." But when something is being done on my body, what I feel is I have every right to understand what is being done and why it is being done. So it's just a humble request to all of you to just look at the psyche of the patients. Thank you.
This is, can I make a counter comment on this?
Of course.
I think you very rightly pointed this out. People like us who have trained in the West and in this country, we've been exposed to something called a communication skill. Now, this was the responsibility of the government who designs curriculum. Unfortunately, in the whole of the history of the Indian medicine, there has been no curriculum on communication. And they are now thinking of actually introducing communication skills. Doctors in this country do lack, and I own up, do lack communication skill. And you have rightly said, this is the right of the patient. And I totally surrender to this, that we are very weak in communication.
Thank you. Thank you for agreeing to that. But just again to look at the positive side of it, we had been to Vellore once for my checkup, and I was really impressed by the patience of the doctor. He went on answering as many questions as anybody had, including me. It went on till late in the evening at night, but all our questions got answered. So there are exceptions. Thank you very much.
Any other questions?
Dr. Roy, so if I understood you correctly, when you were speaking about walking, that walking briskly is a very good idea. You talk to people, to people. Well, have you heard me or should I repeat this?
No, it's okay.
Yes, okay.
But supposing you walk quietly, I walk and I listen to songs as I walk. Is that all right? I mean, is it not brisk walking too?
Yes, it's brisk walking. But the thing is, how you know it is brisk? So I told you that basically once you are walking, if you are not panting, but still you can talk, or you can,
Oh, I see.
Yeah, that is the brisk
It was related to panting. Yeah. I see. Thank you. Yes.
Good evening, everybody. My question is, I'm a patient of diabetes and sir knows me well. So I'm already into insulin. Morning I take insulin, night also I take insulin. Please tell me, will I ever be away from insulin, or till I die I have to be with that insulin? Because people say once you start with insulin, apnar ar mukti nahi. So you please tell me, mukti ache na nahi?
See, diabetes is a disease where the body gradually stops producing insulin. So there will be a time when you will have to replace the insulin with insulin. Unless there's research going on in if you can wake up some other cells of the body to start making insulin, which may happen in your lifetime and in mine, but it's not happened yet. Till that time, you have to take insulin from outside, and because it is a protein, as of now, you'll have to take it by injection. Because if you eat it, it's digested.
Okay, thank you, doctor.
If there are no more questions.
Can you reverse diabetes? I mean,
This was a question I was going to ask. Didn't ask it because of lack of time.
This is the sort of hit on social media at the moment. See, the basic problem is that your insulin production is going to decline. You will find out you're diabetic when about 50% has already gone. Now, with the 50% you have left, what you can do is you can reduce the number of kilos the body has to service. So supposing you were, say, 90 kilos and you become 80 kilos, then that 10 kilos less that the dwindling insulin has to service makes you feel good, makes maybe medicines redundant for the time being. So in that way, you have reverse diabetes, but it is not a permanent reversal.
I'm not a diabetologist, but I think it's going to happen. I think like renal, liver transplant, cardiac transplant, you may have an islet cell transplantation when it's happening now. So, and it's not successful yet, but maybe in future. But I would like to thank all the members. Oh, there's another question.
Thank you. I'm going to ask the reverse question about body weight. We are talking about overweight, obesity, and reduce your weight. What happens when a diabetic patient who is under the care of a topmost dietitian in town, not you, another, so is losing weight, my wife, in spite of eating well, steadily losing weight from 55 kg to 52 to 50, 49. She's eating well, she's under a dietitian's care, taking all the medicines. That was number one. The number two is Dr. Roy. I'm under his care, Dr. Subhanan Roy. And I'm only for general care. I don't have any specific problem. But I am slightly overweight. I'm not obese, and I want to reduce that. But I asked Dr. Roy, and he said, no, don't try to reduce. You are doing fine. Further reduction might lead to other problems. And my son-in-law is a neurologist trained and passed in USA and in Johns Hopkins, etc. He also said, no, you are fine. Your BMI is 27. Don't try to bring it below 25 or something. You are fine. If you reduce that, you may head for other problems, independently of Dr. Roy, he told me. So these are issues, a common man struggles with, what is BMI, what do we aim at? And if a patient loses weight, what does he do, she do?
See, losing weight, if you're eating well and your diabetes is well controlled, we have to look elsewhere outside diabetes. Any system can be a problem, and I think a systematic, orderly approach is what is necessary. But it's not a diabetes issue, that's for sure. Everything has to be, every single step has to be taken in a systematic manner, like a checklist. And then ultimately, I think we'll get an answer.
Regarding your weight, if I may say it, if you are well with this current weight, why reduce it or change it? If you are not well, then that's a good. If you are not obese, you're just overweight. And after a certain age, you do not need to change weight. We are talking about people who have got problems with obesity, and despite medication, they are not getting better. So I think that probably is true for your case, and you don't need to change unless you have got an issue. I think we have been 1.5 hours. We should probably close the session. I would like to thank all of you and my panelists who have been absolutely brilliant, and they are all busy people, and I've managed to keep them here for 1.5 hours. Thank you very much. I'll pass it on to Partha.
Well, thanks to all the doctors. It has been an incredible session, and I hope to repeat this sometime. I will have to announce the best questions, because we earlier announced that we will have prizes for the best questions. The 3 best questions were by Mrs. Jayati Gupta, Dr. Choitali Moitra, and Mrs. Sujata Roy. We have book coupons from Oxford.
So, Mrs. Sujata Roy, Choitali Moitro, and Mrs. Jayati Gupta. Parsuda. And Parsuda, maybe you will go and reach to her. With her Dilbashan.
Thank you. Thank you. Thank you.